my name is Josh Rogers, and today we're going to talk about the diagnostic imaging of asbestos-exposed World Trade Center attack survivors. Our objectives today are to discuss exposures of asbestos that were related to the World Trade Center attack. We're also going to discuss the effects of asbestos exposure, discuss the imaging of asbestos-exposed patients, and determine which are the best imaging modalities to screen World Trade Center attack survivors for asbestos-related lung pathologies. First, let's discuss the exposure to people who survived these attacks. The amount of asbestos in the air peaked directly after the attack of the World Trade Center. If you look at the slide, you can see a graph that clearly shows the background levels being extremely low, which peaked immediately after the attack, which was right around 10 a.m. on September 11th of 2001. Those levels subsequently decreased exponentially in the hours after the attack. And by October 8th of 2001, the levels of asbestos in the air had returned to the normal background levels that were measured before the attack. The greatest asbestos exposure was to the first responders, which included firefighters, police officers, and volunteers that helped at the disaster site. And also to the workers who removed the rubble from the World Trade Center after the attack. These would be both construction and demolition personnel. Their exposure was more from the re-agitating of the dust that had already settled back into the open air and then being exposed to it as they drove the trucks in and out of the city. Other persons of concern are pregnant women and children who were exposed. I'd now like to talk about the effects of asbestos exposure. Asbestos is a known carcinogen and lung pathogen. The main risk factors for developing a lung pathology from the exposure of asbestos is latency, or the time since the first exposure, the length of the exposure, meaning the amount of time that you were in the area actually inhaling the asbestos, a history of smoking, which is of course a direct correlation, and the age of the patient. This is both due to the ability of their lung tissue to clear the asbestos and is also related to the latency, or the time since their exposure. The main pathologies related to asbestos exposure are lung cancer, mesothelioma, pleural thickening and calcifications of the pleural layer of the lungs, sometimes referred to as plaques, and pericardial disease, or any disease related to the sac that surrounds the heart. I'd like to discuss some of the strengths of the different imaging modalities in relation to the different pathologies caused by exposure to asbestos. First, let's discuss lung cancer. Lung cancer is detected superiorly through CT, or computed tomography. CT's ability to distinguish tissue densities is far greater than that of conventional radiography. Thus, it can pick out the pathologies much sooner. Mesothelioma is also detected much earlier by CT for the same reasons. As well are pleural calcifications and thickening, also known as plaques. Another major reason why CT is a superior imaging modality is it can demonstrate these plaques and calcifications without any superimposition of adjoining tissues. This simply means that if a calcification of lung tissue overlays a piece of the vertebral column on a standard chest radiograph, it would just appear as the vertebra. You would not be able to distinguish the calcification due to the higher Z number of the bone and its greater attenuation of X-ray beams. Pericardial disease is best demonstrated by magnetic resonance imaging, commonly known as MRI. This being due to the fact that soft tissues are best visualized by MRI. One study revealed that of 4 patients that were already noted to have different varying lung pathologies through CT, all 4 of them had a pericardial disease, I'm sorry, 3 of the 4 had a pericardial disease that was completely missed through the CT scans. The cross-sectional modalities can better demonstrate lung pathologies by visualizing them free of superimposition, as we discussed earlier. The superimposition of surrounding rims of vertebral structures are most notable. CT and MRI are also more sensitive to the tissue densities than diagnostic radiography, as discussed in the previous slide. With this information readily available to doctors and radiologists, why is an erect chest radiograph still the standard screening method for asbestos-exposed related lung diseases? Well, let's see if we can't take a closer look at that. A chest radiograph has a much lower dose of radiation than a chest CT, and it is dramatically less time-consuming and more cost-effective than an MRI. Up on the screen you can see several images. The one on the lower left is showing a calcified plaque region that appears almost as if it's a mucosal cyst near the base of the left lung. On the right, we can see, and that's a standard chest radiograph also. On the right, we can see a CT scan, and the white arrowheads are pointing at calcified plaques, which on a radiograph were indistinguishable from being either part of the vertebral column here, goodness, and a rib on the lower one. In conclusion, both the duration and exposure, as well as the latent time since exposure, have been relatively short for those that were exposed during the World Trade Center attacks. Most asbestos-related lung pathologies, such as lung cancer predominantly, do not present under 20 years post-exposure. The increased radiation dose from a CT has been weighed, and the formula to justify this increase was determined as follows. If the patient is under 55 years of age, has had less than 28 years since the first exposure to asbestos, and has less than 17 years of asbestos exposure, a CT would be an inappropriate first choice as a screening tool. Let's take a look at what this formula tells us. It points out that with both 28 years of latency and 17 years of exposure, the background levels of asbestos had fallen back to their typical levels in less than 1 month. So this is dramatically less than 17 years of exposure. Also, 28 years of latency since the World Trade Center attacks has not yet happened. The standard chest radiograph is the best primary method for screening World Trade Center survivors for asbestos-related lung pathology. A follow-up CT scan, however, would be the appropriate choice for radiographic findings that were related to lung cancer, pleural calcifications and thickening, and mesothelioma. However, a follow-up MRI would be the appropriate choice for radiographic findings related to pericardial disease. And on these next 2 slides, I've listed my sources. I'll give you just a second to look those over.
Okay, I have a question.
Yes, please.
So, on a chest x-ray, what are some of the things that will be seen because of asbestos?
That's a great question. I actually have an example. We can go back to a larger picture of this chest radiograph. Now, we can see with mesothelioma and lung cancer, and also asbestosis, which was a pathology we did not discuss in this presentation. A lot of the main things you're going to see are those plaques and calcifications, or just general thickening of the lung tissue itself, as well as infiltrates that would sometimes almost appear to be similar to a snow globe effect, like you would get from, say, a fungal pneumonia type situation. But any sort of a, if you'll follow me over here, any sort of a linear plaque that is not associated with atelectasis, as we all know, a collapsed lung is the standard cause of any sort of a linear plaque. But when you see something like this and you still have full aeration of the lung, that would be very typical of an asbestos-related lung pathology, as well as any other sort of a lung pathology that has to do with an inhalation type situation. Did you have any other questions?
Nope, I think that's it.
Thank you very much for your time.